Thank you very much. It is a complete pleasure to be here today to speak to you about this topic and to see all of you here in front of this very distinguished jury. I am very optimistic that important things for this field will come out of these 3 days. And for the field, I'm very grateful that you're spending the time to accomplish this important work. Somebody thought it was important to go back a little bit and make sure we were all on the same page before we move forward, and somebody decided that was my job. So in about 20 minutes, we'll go over 40 years of work. I should tell you that I used to do a lot of training of pediatric residents, and I would tell them on the first day of training, I know how you're feeling because I was an intern myself here in the early 1970s. And then I stopped saying that when I saw this blank glaze over their eyes and realized none of them had been born then. And I suspect that's true for many of you too. But these kids have been born over and over and over again. And the speed with which we are dealing with this problem is perhaps as fast as we can go, but it is far too slow for them. So we go that way. Fetal alcohol syndrome starts as a syndrome. And I thought it was important for you to, first of all, just think about the naming of things. A birth defect syndrome is a recognizable pattern of human malformation. Recognizable does not mean necessarily you can see all the problems, but you can make a list of all of the things you can see and all the internal structural problems that one has found. And when people are a match on such lists, they have the same syndrome. Most syndromes have more than one cause. You can look just like somebody else for a different reason. And because of that, there are any number of ways that syndromes are named. They're named by the people who first discovered them, Prader-Willi syndrome. They're named after the most common body parts that are involved, orofacial digital syndrome. Other people have tried other things, naming it after the first place a condition was found, naming it after the first person who was found to have the condition. Sometimes whimsy. There is a condition where children sound like a kitten crying, and so the condition was called Kritisha. Occasionally, we do name things after etiology. Generally, they're genetic, and generally, again, the kids look very much alike because of the specific nature of the genetic problem. Most environmental agents that cause birth defects do not cause specific birth defect syndromes. Okay? It's not just alcohol. Most environmental agents do not cause syndromes at all. And a few cause syndromes as a part of a spectrum. Why is that? Well, harm is based on a myriad of issues when you're dealing with environmental agents. Dose exposure, timing, maternal factors. Some fetuses seem to be better able to withstand stuff than others, and other cofactors. If you think about common birth defects like heart defects or cleft lip and palate, the reason they're common is because many things cause them. The reason brain damage is common is because many things cause it. We haven't actually spent a lot of time going to cardiac clinics or clinics for cleft lip and palate and finding out what percentage of those kids were exposed to alcohol. It would be an interesting exercise. One would suspect that it's more than a random issue. But we do spend our time wandering through brain clinics looking for people exposed to alcohol, and that, of course, is what we're going to be talking about today. So in the case of environmental agents, we don't usually use their names as a syndrome recognizer. One of the people who spent a lot of time writing the names of syndromes and identifying new syndromes was David Smith, my teacher. And he found this disorder that we're concerned about, like he found a whole bunch of others. He found a small group of kids, mostly in Seattle, started talking about it among colleagues. They gave him a few more cases from their files. He put all that together, and he published a new paper on a syndrome. 11 children who looked alike, whose mothers all had alcohol exposure, was the beginning of this field. And he leapt after seeing 11 kids to the fact that this was alcohol caused, and he broke many of his own rules about naming syndromes and called it fetal alcohol. That's where we started. Well, scientifically, that led to a lot of discussion. How did we know it was fetal? How did we know it was alcohol? And was it really a syndrome? That led to probably $100 million worth of funding from the National Institutes of Health in the United States to carefully investigate all of those questions. In those days, I was starting my career, as was my esteemed colleague and friend Kathy Sulik, and we were both benefited from funding to try to begin to sort this sort of thing out, but an awful lot of other people were too. So what did we know? Was it really fetal? How do we know? Fetal means basically second and third trimesters. The first trimester, when things are forming, is called the embryonic period. How do we know it wasn't embryonic? How do we know it wasn't preconceptual? How did we know it was really alcohol? Alcohol was in there, but was it really causal? Was it correlated? Was it a cofactor? What was it really? And was it really a syndrome? We all knew even then that environmental agents didn't cause syndromes very often. So was this really a unique situation for alcohol, or was this some kind of a tip of an iceberg? Nobody knew. So this is what we learned. Was it really fetal? Well, not exactly. Preconceptual period may be dangerous. The period between implantation and the time of the end of embryogenesis, extremely dangerous. The rest of pregnancy, still dangerous, especially for the brain. There was no safe time, but early, maybe even early when women didn't even know they were pregnant, was most dangerous. Was it really alcohol? Yes, it was. Animal studies make it perfectly clear that alcohol is a real teratogen, and it can cause all the parts of the fetal alcohol syndrome. But could alcohol also be correlated to a whole host of other bad things that hurt pregnancy? Absolutely, and usually does correlate with a whole bunch of other problems, prenatally and postnatally. Could it also be a cofactor? Like alcohol hurts you, smoking hurts you, alcohol and smoking hurts you more? Absolutely. It was all true. And was it really just a syndrome? No. The syndrome was a lucky break. If it weren't for the syndrome, we might still not understand what alcohol is doing to folks. Just like we don't really know what alcohol is doing to your heart. Fetal alcohol syndrome is a real thing, but it's rare. Most people exposed to alcohol who are damaged have unrecognized problems until you really seek them out. Being able to summarize that slide was really 15 to 20 years worth of work by an awful lot of folks. So why do we learn that people seek an FASD diagnosis? Well, usually it comes late. It comes after several years when a child has abnormal behavior that is inexplicable. These children are mysteries. They have gone to traditional sources for traditional help, and they still are having trouble getting along at home, at school, in society. And traditional medicines and manipulations of behavior haven't worked. It's possible for some kids exposed to alcohol, of course, that if it did work, they don't show up. The ones we see are the ones who are really mysterious. The mystery may not be obvious until kids are 6 to 10 years old. This is not always apparent in small children. Another problem for us. I just put in this slide to say everyone else on this panel will discuss the fact that alcohol really does hurt the brain physically. And my colleagues will elegantly show you that that is so. Now, we're here today to talk about people with abnormal adaptation. You don't get to go to jail unless you're not doing things properly. The people who don't go to jail are on this slide. They have normal adaptation. And what that means is that they have normal temperament and mood. It means that their brains work properly and at a level that they understand the world around them. And it means that their environment and learning have been supportive. And when all of those things are within the normal range, it's likely that you will act normally in society and move along with your life appropriately. Here's the important point for the jury, I think. If you have psychiatric conditions, severe depression, anxiety, obsessionality, what have you, psychosis, if you have a decreased intelligence or these dysregularities of brain function and process, if you have severe medical issues that have not been managed properly or in an adverse environment, any one of those things by itself can lead to maladaptation. Any one of them, or two of them, or all three of them. Most of the kids we see with an FASD have all three. That's the mystery. And they all look alike. I mean, one maladaptive person looks like another maladaptive person. The etiologies are not necessarily clear by looking at the person or simply taking a history. This takes real work to evolve this. And obviously that's important because if somebody's maladaptation is due to a psychiatric condition, it would be obvious that you would treat it very differently than if it was an environmental disorder, and totally differently than if they were truly disabled because their brain was structurally abnormal and not processing correctly. The etiology of the maladaptation will drive treatment and drive expectation for the future. And it is a mystery unless a huge amount of work is done to unfold that. Who should do such work? That's why we're having this meeting, because it's not clear who does this work. Clinical geneticists, by and large, diagnose syndromes, but most of them have not been trained to really do any hands-on work to understand brain dysfunction. The brain conditions that we've just talked about can be evaluated by other people who can be in developmental medicine, in psychiatry, in psychology, but none of them take full responsibility for all of it, and none of them are trained to do that. So no specialty exists that is fully trained to evaluate the structure and the function of the brain and then to recognize that as a component of a syndrome. And it's for that reason that we began multidisciplinary diagnostic teams. Not because we thought we should have a party once a week to do this work, but because there was no way to do the work without multiple expertise seeing the patient at the same time. Those clinics, the first one was in Seattle. I started it with a group of colleagues. They have grown around the United States. There are 35 of them in Canada. They see 2,000 people a year. That is terrific compared to other parts of the world, but it is trivial compared to the need. More importantly, when we see these kids, interestingly, they're usually not living with their birth families. And the opportunity to do what we often do in genetics, which is start with a first case and then look for other cases in a family and do prevention and screening, kind of stops with FASD because the kids are isolated. Moreover, we have found that educational and social systems have generally not been very responsive because they don't get it either. And the complexity of these kids' disorders and the lack of data provided to those systems have not yielded terribly effective services. And consequently, it has not been clear which prevention measures should be successful or who's responsible for the task. Everything hinges on quality diagnosis. Quality diagnosis hinges on fully understanding what's going on in individual brains. Keep in mind that everyone exposed to alcohol is not damaged by alcohol. And everyone who is damaged can have a different pattern. So, again, at this point in time, and I fear for the likely future, we need to build teams that don't exist. We need these teams urgently. To do what you want to do in the legal system, we need teams for you. Now, all of these things work together. Diagnosis informs prevention, intervention. Everybody needs surveillance or we don't know what we're doing. You really can't separate them. But if you look at the arrows, I think this is true, that every arrow leads away from diagnosis. Without it, you can't do any of the rest, really. It's likely we'll get better tools in the near future. Epigenetics looks very hopeful to identify actual genetic explanations for alcohol teratogenesis. I'm optimistic that that will come. But when it comes, it's still not going to give the courts the answers it really needs as to why the child's behavior is abnormal. So in summary, in my view, it is essential that the nature of the diffuse brain damage is consistently evaluated so that the court can understand the manner of maladaptive behavior that is presented. If you're getting different kinds of information on different kids, we're not going to get consistent and appropriate rules. In my view, it is the diffuse brain damage and not its cause that should be the mitigating factor. As with cleft, lip, and palate, if you take 100 kids with cleft, lip, and palate, maybe 10 of them were exposed to alcohol, and that's the reason. But we treat everybody with a cleft, lip, and palate. It's just the same. That will require a medical system and legal systems that are working together to organize a medical response that's timely. This requires that medical groups and legal groups are working together to understand the needs and limitations of each other in order to bridge the gaps between our fields. Thank you.
At this point, I'm going to ask the jury if they have any questions of Dr. Clarren, and we'll hopefully have some time at the end for the delegates to ask questions. Are there any questions from the jury? Yes.
A question arising out of the three comments made. One is that you say damage, not the cause, is the mitigating factor, which objectively is what the legal system has to deal with. Secondly, you said that most individuals exposed to alcohol have partial expression, with the brain being the most commonly affected part. And then thirdly, that everyone who's exposed to alcohol can be damaged in a different way. So there is this huge variation within FASD, both as to the severity of the functional damage, its expression, and this becomes very difficult for the legal system to deal with because it's a very elusive concept to put in front of a court and say, therefore the sentence should be this, that, or the next thing. Is there any effort within the field to try to create some system of categories or scales that would provide some objective measure that the court could grab onto?
Your Honor, I really wish it were simpler. I truly do. And the reason we're here today is because we're recognizing the dilemma you've just described. what we need is more data. The data is actually coming, I hope, to answer your question. I represent an organization called the Canada FASD Research Network. We have linked all the clinics in Canada together to collect real-time data on what they're seeing, so that we're not only collecting the FASD diagnoses, but the actual functional diagnoses of the patients. What is the most common finding? Executive functioning, social communication disorder, memory, and so on. What are the most common patterns? We will have the first data in the world on those findings soon, probably by this winter. That should help us begin to do what you're saying, start to put a simpler approach on which kids are which. Until that happens and until people agree on the scoring system, I don't see any way out except to have people come to court and explain the full abnormalities of the patient you are seeing and how those abnormalities may relate to the crime. But to recognize that that's what's needed, at least today, is important, I think, and I don't think it's been recognized as yet.
If we could take one more question from the jury.
Dr. Clarren, you mentioned that there are approximately 2,000 diagnoses made in Canada last year. Is that correct? Complete or diagnosis completed?
I'm sorry, I'm having trouble understanding.
You mentioned the number of cases that were diagnosed last year in Canada by these multidisciplinary teams. What was the number again?
Okay. There are approximately 2,000 diagnostic slots in Canada, an opportunity to diagnose people that many times. The number of people who are actually diagnosed is far smaller than that.
Right.
And it's actually a difficult number to fully get to. But one would guess perhaps 50% of that, about 1,000 actual FASD diagnoses a year in Canada. But about 2,000 people have the opportunity to be evaluated.
Good. And could you tell us how those cases are selected and what the cost is and who pays the cost for them? That's not a simple answer. I'll do the very best I can very quickly. Most clinics see people who are referred to them. Many clinics have age ranges. There are very few clinics that see people birth to late adulthood. But there are some programs that see little children, some that see 5 to 20, and there are a few clinics in Canada, a handful, that will see adults. Largely it's because the psychological tools are different for the diagnosis. In most cases, people are referred either by themselves, by professionals. There are different rules if you have to go through a pediatrician or not to get there. The entry criteria are usually that there was some evidence of exposure and some evidence of this mysterious brain, that people have had a history already of failing treatment and the family is frustrated. It's those two things that drive entry. The cost of these evaluations vary. It's probably a $3,000 to $4,000 exercise if we did it tightly. That's about the same price as some brain imaging. Takes a lot longer, but it's about the price. It's paid for in a variety of ways. Sometimes it's part of this health system, sometimes it's fee for service, sometimes it's part of a philanthropic organization.